This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and we have an interesting case. This is an elderly male patient who has this long-standing cataract. There's a vague history of trauma many years back, but the patient is not sure. You can see a small corneal scar here. Clinically, what we see is an hypermature cataract with a moderately dilating pupil. We're suspecting some amount of zonal adhesions in the inferior quadrant, and this is the situation now. The surgery is being done after having explained a guarded visual outcome following the procedure, owing to the complexity of the cases, and the posterior segment on B scan was normal, but we still can't be sure about the health of the optic nerve head or the macular health. So the challenges here would be, I'm not sure whether we can save the bag in this eye. We'll be trying to use either capsule hooks or the CTR, depending on the situation, and if required, maybe a CTS as well, and then take a call. And in the worst case scenarios, if the bag is not salvageable or is not worth saving it, then I'm also ready with my iris clip lens as well. So this is a planned scleral incision is being done because in the worst case scenario, I have an exit route and it's also easier to place the rigid PMMA iris clip lens. The plan is to do the rhexis first, assess the capsular health status, the bag health status, zonules, presence or absence of vitreous, and then take a call whether to perform phaco or not. From the outside, it looks the cataract could be soft, but only after the rhexis is done and the milky cortex is taken out will I actually be knowing the density of the nucleus. So the side ports are made, the capsule is stained, OVD is placed into the eye. So to begin with, I'll be planning to go in with just a 2.8mm incision and then take a call later on. And as soon as the OVD is placed and the pupil expands a little bit, we can clearly see the amount of zonal adhesions which is there. It's about 3 clock hours in the inferior quadrant. I'm using the Y hook to separate the posterior synechia in the superior quadrant. I'm just trying to release all the adhesions between the iris and the anterocapsule. The pupil is well dilated, but there is an area of the capsule which is not stained well. So I go back with my trypan blue and repeat the staining procedure. It's just like painting with drops of trypan blue, although it's not as effective as being done on a virgin capsule, because once the OVD sticks onto the capsule, the staining is not appropriate, but still something is better than nothing. So now we have a decent visualization of the anterocapsule. The most critical step in this case is to get the rhexis right. If you get the rhexis right, then we have a potential to place the CTR inside, or we can also support the bag with a capsular hook if need arises. Now with the lens being subluxated slightly, centering of the rhexis becomes a challenge. So in this case, it's mandatory that we center the rhexis on the lens rather than based on the pupil. There are few areas of fibrosis in the anterocapsule and calcific spots, and I'm using a 26 number blunt needle to raise the flap and try to fashion my rhexis. There is some amount of intumescent in the lens as well, so I switch to forceps now, and I'm trying to center my rhexis according to my original plan. That is, trying to be a little bit eccentric towards the superior quadrant. So I'm trying to do the same thing. So I'm trying to be slightly more eccentric towards the superior aspect so that I can compensate for the inferior subluxation. That's my idea. And my aim is to have around 5mm rhexis. So the goal is to achieve an optic capture of the lens by placing it in the sulcus in worst case scenario. So there's a reason I want to size the rhexis well enough. Thankfully the rhexis is done. It looks to be decent size and decently well centered. Now I need to place the CTR first before managing nucleus. So one tip to place the CTR in eyes which have the nucleus in the cortex in situ is to do some cortex aspiration in the area where you're trying to introduce the CTR. So there are two advantages. One is you got the lesser amount of cortex being entrapped under the CTR. The bigger advantage is you have created a little bit of space so that the CTR can be easily negotiated under the anterocapsular rhexis margin. So another tip here would be to use a cohesive OVD like sodium hyaluronate. I'm injecting sodium hyaluronate under the anti-capsule and inside the bag. What this does is it creates and maintains the space within the capsular bag. It acts like a artificial zonules momentarily until the CTR is being threaded in. And it also reduces the amount of stress which is being induced on the healthy zonules when the CTR is being maneuvered in. These are the couple of advantages of using a cohesive OVD inside the bag when you're trying to thread in a CTR. Again, we need to be moderate. We cannot overfill the bag. The CTR is being introduced about 5 clock hours ahead of the area of zonular disinsertion, simply because this is my area of comfort. And because I've stabilized the bag with the cohesive OVD, so even the maneuvering, you can hardly see there is any deformation of the bag and any stress on the healthy zonules. But its care has to be taken that the CTR covers the entire span of the zonular dehiscence and comes way beyond it. And because the pupil is well dilated in this region, we can clearly visualize as the distal eyelet traverses across the zonular dehiscence area and goes beyond it. As this is being done, you can always see that my left hand is supporting and compressing the CTR. Now, I'm in a comfortable situation because the bag is now well stabilized by the CTR. And you can see there's an empty space in between the nucleus and the CTR in the 6 o'clock area. So as I'm trying to aspirate the cortex and the epinucleus superficially before starting my phaco, the clear space is very much visible. So what I do now is with my left hand instrument, I just nudge the nucleus away from me towards the 6 o'clock so that the nucleus becomes well centered and the gap which was there between the equator of the capsular bag and the nucleus is reduced or almost disappeared. So now we're trying to emulsify the nucleus with the nucleus held in its proper position. The nucleus is very soft, thankfully, and it's quite easy to manage. I'm just going to do a trench, divide the nucleus into 2 halves and then divide them into smaller fragments and aspirate. Now this is an easier part of the surgery. At this stage, it's very evident that there is no prolapse of vitreous because there is no change in the antechamber dynamics as well as the followability is excellent. The why I'm talking about this is there is always a possibility of transzonular migration of vitreous into the antechamber. If it happens, usually we can see that the bag becomes decentered and the chamber becomes suddenly deep and starts fluctuating, and none of this is happening. That's a good thing, and so the nucleus is finally emulsified. We're left with some cortex. But what is slightly disappointing for me is the red glow is not very healthy. It looks like maybe there's some amount of chororetinal atrophy at the macula. That's how it looks like. These are Elschnig pearls on the posterior capsule. I'm using BSS to just flush them around, loosen it, and then I'm going to use the bimanual I&A to aspirate all these pearls. So at this stage, I still feel that the capsular opening is slightly eccentric. So I want to enlarge the rhexis margin a little bit using a micro scissors in the forceps, and that is done. The bag is inflated with OVD. So I want to place the multi-piece lens in the sulcus trying to achieve an optic capture. And that's my goal. That would probably ensure a late onset dislocation or decentration of this capsular bag. That's the idea. The CTR is in the bag and I'm going to place the lens in the sulcus. Before achieving the optic capture, I'm just going to remove the OVD from behind the lens. Once the OVD removal is done, the optic is pushed back. And unfortunately, we don't have a 360-degree coverage of the rhexis margin simply because it's slightly eccentric. But nevertheless, I would like to keep the lens just like this. And I'm going to check for any vitreous prolapse before closing. And thankfully, there is none. The dilated transference state is just washed off. Intracranial antibiotics are placed, the wounds are hydrated, and the conjunctival flap is then cauterized. In this case, the intraoperative events were much more subdued than what I had expected and prepared for, and this 3 to 4 clock hour zonular dehiscence was very well supported by the CTR, and the patient continues to do well over a long period of time. So that was it. Thank you for watching and hope you found this helpful.